So I guess we'll get started. Good evening and welcome to the George Wylie Center. Thank you for coming. As you can probably tell from the slide, tonight's discussion, and we hope to make it a discussion, will be single-payer health insurance or Medicare for all, which, if you've been following recent political debates, has been a very prominent feature. Most of the two Democratic debates, I think, started off with this, and the debate over it went on for quite a while. Who are we? We are physicians for the National Health Program of the Rhode Island chapter. I'm Dr. Mark Bryant. Jim Callan, who will be talking in a minute or two, will remind you who he is in a second. And Linda Uchifusa, who is, full disclosure, my wife, is kind of acts as the secretary for the Rhode Island chapter. So, unlike other talks we've been to recently, we do have financial disclosure slides. We have no financial disclosures. We are so far beneath the contempt of the insurance industry that they don't even try to bribe us. So, as far as our relationship with PNHP, we actually give money to it rather than vice versa. So, they have dues. So, what are we talking about tonight? Well, we're talking about a fundamental change in the way we fund our healthcare systems. That's all we're talking about. Not how healthcare is administered, how do we pay for it? And that's been really the heart of the debate in the last few Democratic debates. Medicare for all is what we're proposing, and it is really very simple. You have on the left, us, people who may need health care. You have on the right, doctors, hospitals, pharmacies that dispense things that are needed for health care. And in order to make this happen, this being the United States, we're all capitalists, you need money. So the money has to flow from us, the patients, to these providers of care. How does it get there? Well, that's the problem. Because right now, it has to pass through a large number of other entities. Blue Cross, United, Cigna, WellPoint, Medicare, Medicaid, TRICARE, the VA, smaller health companies that are funded by or promoted by the employers. And there are many of these companies. They all require money to run. And that is part of the problem why our healthcare system is so financially inefficient. So, single payer cuts through all of this and eliminates the middleman. Who delivers the care doesn't change. Who needs the care doesn't change. The only thing that does change is how does the money flow? And instead of having many institutions which soak up a great deal of the money, you have one institution, which in this case would be the federal government, Medicare. And that's really all that we're proposing. This is not socialized medicine. I don't think that's a bad model, but it is not what's being proposed in these bills. Socialized medicine would imply that the government owns the hospitals, employs the doctors and the nurses and the pharmacists. That's not what we're proposing. We're just proposing changing the way we fund healthcare. And that's what Medicare for all is. So why do we think this is such a good idea? And Dr. Callan will embark on that discussion.
Well, my name is Jim Callan, and I'm a doctor, but I also worked for practice medicine for 20 years and worked for Aetna, the health insurer, for 15 years. And I'm going to speak to you now about why a single-payer solution is actually the only solution to the two problems that we have with access to health insurance in the United States. One of which is that access. There's still 20 million Americans actually don't have health insurance, despite Obamacare and other improvements. So there's a problem with access, and there's also a problem with the cost of health care. And these two problems are different problems. But I can guarantee that probably there are people in this room who've had problems with access to healthcare. I was speaking to a lady a few minutes ago who described the problems she faces. And there are certainly, everyone in this room has a problem with the cost of healthcare, because as you'll see from Mark later on, it costs far more than it does in other countries, and there's no good reason for that except profit motive. So, what I'd like to do is to lay out before you some very simple things about the way that health insurance works and why the system that we have at the moment is doomed to failure no matter how it is tweaked. And we should have learned that lesson over the last 80 years since health insurance was just introduced in the US, and it's constantly had problems with providing access to everybody and keeping the costs down. So The first thing that you have to grasp is that you can't insure a person's health like you can insure your house or your car. And the reason for that is that if you own a house that costs, say, $100,000, if it burns down, the insurance company has to pay $100,000. So they know when you buy the insurance how much it's going to cost them if your house burns down. The same if you total your car. How much is your healthcare going to cost next year? There's no one in the room that can answer that question. And that simple fact demonstrates that insuring a person's health is different from insuring an object like a car or a house. So to get around that, what you can do is if you come to me and you say, well, I don't have one person to insure, I have 100,000 people to insure, a big group of people, then I can tell you that out of that 100,000 people, 8 of them will get leukemia on average every year, and 3,000 of them will have a heart attack next year. I don't know which ones will have a heart attack, but I know that 3,000 will, and so on and so on. So I can tell you how much the cost of 100,000 people will be next year for their health, but I can't tell you what your cost will be for your health. Everybody with me?
Yep.
Okay, so that means that you've got to have people in groups to insure their health. And that is why you get your health insurance through your employer, because that's a group of people, employees, who are all there grouped together. Or you get it through the government, which is a group of peoples over 65, Medicare. Or you get it through people that meet certain criteria for Medicaid. And the health insurance works pretty well with when you are in a group. But what happens with groups is that when you have one group of people, say, who are insured by United, and another group of people insured by, say, Cigna, what's the best business strategy for the United people? And the best business strategy for the United people is to push all the really sick people onto Cigna. Because then United's costs will go down and Cigna's costs will go up. And all of this is about cost, revenue, and profit, and Wall Street shareholder value. So when you have groups of people, all insured by different entities, then you get this competition, this race to the bottom to avoid insuring sick people. And that's why the health insurance markets fail in the United States. So groups are good, but if groups compete one another and make it difficult and expensive to insure people, then the solution to that is to have just one group. And when you have one group, then you can't have this big idea of pushing sick people off to another group because there is no other group. So a single payer will make the insurance, will solve the access problem because everybody will be insured. Now, the other thing that you should be aware of is that in the US healthcare system, it's widely accepted fact that 30 cents of every dollar that's spent on healthcare doesn't actually improve anybody's health. There is a 30% inefficiency or waste in the US healthcare system. So as a capitalist, if I was speaking not to an audience of people who were interested in single payer, but to an audience of businessmen who wanted to do something about their costs for healthcare for their business, then what I would say is that if you are a capitalist businessman, you wouldn't pay your labor force 40 hours a week and have them work 27 hours a week. You wouldn't buy your supplies from somebody at $100 a unit and then only get from them $67 worth of supplies. But that's what you're doing with your healthcare. When you buy health insurance, then you're buying something that is highly inefficient. And a single payer solution eliminates a lot of that inefficiency. So it's actually good for individuals and it's good for businesses too. So this is what might seem like a socialist solution. Mark's already said we're not advocating socialized medicine where the doctors and hospitals are employed by the government, but we are advocating something different from a free market model, because the free market model doesn't work in health insurance, and it doesn't work in health insurance because you can't insure that individual's person's health. What else do we have here, Mark? Is that it? So we need a little creative destruction in this system. And you will hear arguments from politicians, as you'll see later, who are paid by the health industrial complex, that we can't make this transition because it's too difficult. Now, the buggy whip manufacturers, when the automobile arrived, might have argued it was too difficult to have automobiles on the road and so on, but they lost out. And people who were advocating for votes for women, universal suffrage in fact, civil rights, gay marriage, all of these people were told it's too difficult, but it happened anyway because it was the right thing to do. And that's how you should think about health insurance. We have a good solution. There are many people who have a vested interest in the current state, as we'll lay out for you, and those are the voices that you will hear. And when you hear that said, you've got to ask the question, who's paying that person to speak? We've told you no one's paying us to speak, because this is the right thing to do. And we're going to show you how to look and see when people are talking about this and they tell you that it's too difficult, how to sort out where their money is coming from and why they're telling you that. So what do we have next, Mark? Okay, Mark is going to lay out some of the consequences of our current healthcare system, which are pretty scary.
Hey, thanks, Jim. So we're going to do this the whole talk, so don't get confused that we keep getting up and getting down again.
No
problem. Thank you. So anyway, so there are actual consequences to this besides just the cost, and this is one of the most appalling, is that Medicare actually, you can demonstrate that it actually improves the health of people in this country. This is a graph comparing the average life expectancy of the US compared to other industrialized nations by age. So 0 to 1, 1 to 4 years of age, 5 to 9, 10 to 14, all the way up to 95 to 99. And you can see that earlier on, the US ranks extremely low. We're 17th of these industrialized nations as far as our life expectancy, and we pretty much stay near the bottom of that group all the way up until age 65 when something magical happens. Life expectancy starts to soar. By the time you get to the age of 95, we have the second longest life expectancy in this country after Japan. What changes at age 65?
Medicare.
Thank you. So, I mean, that's an interesting slide, but think of this big gap here. What is this big gap? This is people who should have lived and didn't. So, this, graphs like this are interesting, but when you think about what they represent, all the lives lost on the left-hand side of that slide because we can't get healthcare funding right, it's enough to make you crazy. Yes, please.
Yeah, if I were talking to an audience of businessmen right now, what I would point out is
that's a really good
that these people here, between the ages of 20 and 65, that's your workforce. You have a smaller labor pool than you would have if these people were healthy, and because they're not working, they can't buy your products and services, so you have a smaller market. This is not good for the United States, and it's not capitalist efficiency either. We need a little creative destruction here again.
Rather than just destruction. So where's the money going? Jim mentioned that about 1/3 of every dollar that's plowed into our healthcare system isn't used to actually fund healthcare. Well, one of the places it goes is to all that friction, all of that competition among insurance companies. And this is a graph that shows in green the increase in the number of people actually providing healthcare since 1970. And in red, the people who are actually involved just with the clerical work, the paper pushing, the form processing, the denials of service. And the numbers look rather different. So over this period of time, and the people who put this slide together, this is David Himmelstein and Steffi Wohlhandler, who actually founded PNHP. They only made the green line as thick as it is so that you could see it. It's actually skinnier than that if this thing were to scale. Over the same period of time where the number of actual people providing healthcare in this country rose perhaps 4%, the number of people actually involved in the administration of healthcare rose 3,000%. So what are the consequences? Massachusetts General Hospital, we've all heard of it, it's a famous hospital. They have more people in their billing department than they have beds in the hospital. 350 people at last count that I'm aware of. Toronto General Hospital in Canada that has a Medicare for All system, roughly the same size and the same number of people served as Mass General. Guess how many people they have in their billing department?
1.
3. Good guess though. I am told one of those people handles Americans who fell ill while traveling in Toronto and had to wound up at Toronto General. That may be true or not, I don't know. But this red, these people are not doing useful work. They are actually impeding the delivery of care. And we are spending a great deal of money so that they can continue to do this.
So the 30% waste I mentioned, that red section of the graph, that's part of the 30% waste.
Yep.
Yep. There are other sources, we can get into that in a second. So one of the myths that we talk about is that we have a privately funded healthcare system in this country, which is not true. Over almost 2/3 of the money that's going into our healthcare system is actually coming through the federal government. There are various ways it does that. Tax subsidies, mainly to employers who subsidize their employees' health insurance, government worker benefits, the VA, which is a truly socialized medicine. The hospitals are owned by the government, the doctors are employees of the government. Medicaid, 17%, and then of course Medicare as it now exists, 20%. All of them together outweigh the amount of money that's coming in through the private sector. So we actually have a mainly publicly funded healthcare system already. Yes?
Can I ask, what's the difference in the people who are covered by the private and the public funding? Is a majority covered by the private funding?
The people in the private sector, their health insurance is mainly funded by their employers. You can look at that in a number of ways. The employers are paying for their health care, and it's also people who are self-employed. You could also say that 35% represents wages that they should have been paid that instead were used to pay for their health insurance. But even that, that's 35% just from the employer, which ultimately is coming from out of their own pockets. But the 10% is added to that, and private advocates usually say this. But again, when your employer helps to pay for your health insurance, they're being subsidized by the government. They get a tax write-off for doing that. So that money is actually, even though it is coming through the health, ostensibly your health care is being paid for by your employer, 10% of it is already being paid by the federal government. And then when you think about the rest of it, ultimately, where does all this money come from? From us.
I think it was your question how many people are covered on this pie chart? Yes. Okay.
Oh, I'm sorry, I misunderstood the question.
So the answer to that would be there's about 180 million people who have typically private insurance through their employer or some similar thing. There's 330 million Americans roughly, so the rest of them are covered through some program that the government is funding. This pie chart represents dollars. What I've just described represents a head count.
Okay.
Is that helpful?
Yeah.
Thank you.
So, pursuant to what I was just saying, this is getting back to, how do we know our system is inefficient? Well, we spend roughly twice what any other country does per capita on our healthcare system, despite the fact, as Jim pointed out, we still have 20 million Americans completely uninsured, and a larger number that have inadequate insurance that has such high co-payments, deductibles, etc., they can't really use the insurance. Switzerland, Germany, and Holland, have kind of risen nearly to the top of the European costs because they've actually introduced market reforms into their healthcare systems in the last 10 years. But even Switzerland, which is probably the most capitalist country as far as its healthcare is concerned, still is dwarfed by the amount of money we spend on our healthcare system. So all of these countries have guaranteed access to healthcare, universal health insurance, and yet they spend less than we do. And we don't have access. So when you hear people talking about we can't afford switching to a universal health insurance plan, we're already paying for it. In fact, we're paying more than other countries do, but we're not getting it. So the idea that it's going to cost more to insure everybody is nonsense. We can't figure out the same solutions that every other industrialized country on earth has already solved. Really?
Well, maybe we should talk about the future study.
Yeah, okay, why don't you do that?
Well, to this question, would Medicare for all bankrupt the country? Is it going to cost an enormous amount of money? The Koch brothers, I guess you all know who the Koch brothers are, okay? They funded a study done at George Mason University, which is basically funded by them, so you've got to be immediately suspicious of anything that comes out of George Mason University. And that study by economists there revealed that over 10 years, a Medicare for all type plan in the United States would save $2 trillion. Now that study got buried, but nevertheless, even when Koch brothers funded economists look at Medicare for all, then what they when they add up the numbers, there are savings to the country as a whole of $2 trillion over 10 years. And those savings come from where? Well, they come by having less of that 30% waste that's in the system. It's not money that just falls out of the sky. We understand where that savings would come from.
Okay, do you want to talk about the bill? Okay, all right, so right now, and this is why we're having you sign postcards, by the way, there are two bills in our Congress that would create a Medicare for all. The first one, and this is why we're having you sign these things, is S1129. This has been introduced repeatedly over the last 15 years, mainly by Senator Sanders of Vermont, and our Senator Whitehouse actually changed his mind about Medicare for all on its most recent iteration and signed on as a sponsor. Senator Reid has yet to do so. We have talked to him a number of times, and he is still kind of not in favor of it. I think if enough of his voters tell him they disagree with him, he might change his mind. But the other bill that is going to create this is the House bill, which was formerly being sponsored by John Conyers, Michigan. He's no longer a rep, so now it's been taken over by Pramila Jayapal, who's a representative from Washington State. There are differences in the bills. Both of them is similar in that they guarantee universal access to health care. Everybody is on a single-payer system. The coverage is comprehensive in both bills: inpatient, outpatient medical care, emergency room visits, lab fees, x-ray fees, all of that. Pharmaceutical costs are covered. By the way, both bills make a point of saying that the Medicare for All plan will be allowed to negotiate better drug prices from pharmaceutical manufacturers, like as in Canada. Dental care, audiology, vision care, a lot of stuff that currently isn't being covered by Medicare would be covered in these bills. Yes?
Okay, question, the House bill, do you have a number on that, Mark?
1384, it's HR 1384. I didn't remember, but
Okay, thank you. That's all we
yes,
need.
the PNHP people very kindly slipped it in there. Or did you change that, Linda? I can't remember now. You might have altered it. Okay, anyway, because these slides may have predated the current bills. So, all USA residents are covered. Both Sanders' bill and I think Jayapal's bill both say we should be covering documented residents, but also undocumented, which I certainly think. Since it's a single payer system, doctors and hospitals, the network is universal. If you are going to be a physician and seeing patients in this country, either you accept Medicare or you don't see patients. And currently, with these private networks, each insurance company has its own network of doctors and hospitals, so you are limited in your choices to where you can go. That goes away under Medicare for All. If you are a Rhode Island resident and you want to see a specialist anywhere in Rhode Island, anywhere probably in the US, under these bills you can do that. Currently, I'll give you an example. I had a patient who was on Coumadin, had to get his Coumadin checked every couple of weeks. He and his wife had a house on the Cape. Every 2 weeks he would have to drive back into East Providence to a Rhode Island lab to have his blood test done, drive back to Cape Cod, because Rhode Island Blue Cross would not pay for lab tests done in Massachusetts, even though the lab test was like 40 miles away. So that goes away under our Medicare for All system. You choose your doctor, no premiums, no co-payments, no deductibles, and no nasty surprises afterwards. Deductibles and co-payments are unique to the United States, and it is quite clear that they are there to discourage Americans from getting health care, which is one of the reasons why Americans see the doctor less times during the course of the year than any European country, why we go to the hospital fewer times in any calendar year than any European country, why we generally get less care than Europeans. Prescription drug price negotiations, I mentioned that.
Can I say something?
Yes, please.
Just go back to this.
Yeah, I'm going to go back to the slide.
I would just like to make a couple of comments about premiums, because we don't have this mentioned anywhere else in the presentation. And if you go back to the issue of you can insure a house and you can insure your car, but you can't insure your health, you can't insure your body. One of the reasons that the cost of healthcare is unaffordable to most people, and the cost of a health insurance plan for a family today is about $25,000 a year. The median income, 50% of people in the US make less than $56,000 a year. So you can see right away that most Americans can't afford to pay the full cost of their health insurance. Now, that's partly because healthcare costs too much. But the other part of the reason is this, that if you have, say, a $100,000 house, presumably you buy that house because you can afford to buy a $100,000 house. And you won't get a mortgage if you can't afford it. So the cost of your house is proportional to your income. And if you have $1 million house, then you obviously must have a bigger income to do that. If 1 in 1,000 houses burns down every year, then the premium for insuring a $100,000 house is $100 a year. $100 from 100,000 houses, from 1,000 houses, will pay that $100,000 if somebody's house burns down. And $1 million house, the premium is going to be 10 times as much. It's going to be $1,000 a year. So if you're a person of modest means and you have a small house, then your home insurance premium is also small. And if you're wealthy and you have a big house, then your home insurance premium is a big number, but you can afford it. But we don't pay for health insurance like that. What we do with health insurance is we charge everybody the same. If you're employed by a company and you make $15 an hour, then your health insurance contribution might be $400 a month for a family. And if you work for that same insurance company, that same health company, and your salary, you're getting, say, $60 an hour, you will still pay $400 a month for your family's health insurance. Now that makes no sense, because it means that people who have low incomes, then they cannot afford health insurance, because the health insurance is priced at the average price for everybody in the community. It's not proportionate to their salary. Are you tracking with me? Or do I, yeah? Okay. Okay then. So the analogy that I like to point out here is that this is actually it's a constitutional problem in the US, because we have two ways of looking after the health of people. One is the healthcare system, and the other is the Department of Defense, which protects the integrity of the United States physical geography, and it protects our citizens against attack and damage to their health by foreign entities. How do we fund the Department of Defense? We fund the Department of Defense, and we have done since the country was established, through general tax revenues. It's right there in the Constitution that we have a Department of Defense and it's funded through general tax revenues. What we don't do with healthcare is this. Let's suppose the Russians or the Chinese are over that hill there and they're going to attack us. And they come to me and they say, hey Jim, you know, you're a doctor, you paid a lot of money last year in taxes, so we're going to send a battle tank and a nuclear-tipped missile on your behalf to fight the Russians and the Chinese. But you, Mark, you didn't pay much in taxes last year, so the Russians and Chinese are that way, here's a hand grenade, good luck. We don't fund our defense system like that, but that's how we fund our healthcare system. And it's intrinsically wrong, and that makes health insurance too expensive for most people. It needs to be funded, as we said in this point, it says it up here, no it doesn't say it up there, but it needs to be funded through general tax revenues so that you pay a tax for healthcare which is proportional to your income. You may well pay less than somebody else down the street who makes more, but that's the way that we pay for many things in this country. We pay for our highways through that sort of progressive taxation, and we should pay for our health insurance through that progressive taxation. And if you do that, then if you make less than about $270,000 a year, you would end up paying less for healthcare than you do now. If you make more than $270,000 a year, then you will pay more for healthcare. And if you make a lot more than $270,000 a year, you're going to pay a lot more for healthcare, but that's what we should be doing in this country.
Okay, this is kind of just the companion slide to the last one. So we've discussed what a single-payer system accomplishes, and this is what is kind of not maybe emphasized by people who are talking about this during the debates. We hear a lot about they're going to take your health insurance away, people will be put out of work, we can't afford it, but when you sort of consider what is happening right now and what isn't fixed if you don't go to a single payer system, it kind of makes the argument. So if you allow the private insurance companies to continue doing what they've been doing for the last 80 years, costs continue to grow. There's nothing there to restrain that. Millions are uninsured and will remain uninsured. In the last 3 years, even with Obamacare fully implemented, 3 million more people have lost their insurance because premium costs keep going up. There's no control on that. Drug prices are not being controlled right now. There's a lot of discussion about how to do that, and maybe you don't need a single payer to control drug prices, but when you've got 50 different insurance plans all negotiating separately with the pharmaceutical industry, you do not get efficient negotiations nor uniform costs, and you still waste money. The plans being discussed other than single payer may not be able to fund all necessary care. They don't eliminate premiums and deductibles, as Jim just said. They don't allow you a choice of doctor because every insurance company has to have a network to try to keep costs down. Each insurance company negotiates a contract with local doctors, local hospitals, and that's how they help to keep their costs under control. They can't just say, you go to any doctor you want to and we'll pay whatever they ask. That is not how they work. And again, if we don't get to a single payer system, none of this happens. We don't get real change, we don't get real savings. So this is stuff that has been brought up. We actually did this slide after the two Democratic debates because a lot of these points were being brought up during the debates. And one of the big ones, and this is certainly was made by several of the candidates who are not in favor of single payer, was that things you want or need will be taken from you. So did you want to address that one, Jim?
The next slide.
Is that the next slide? I think it's this one. Anyway, so why don't we just go through these really quickly and then we can get some of the next slide. So the emphasis here is that you'll have the insurance you love will be taken away from you. Does anybody, hold up your hand if you love your insurance company. And yet, the people on television seem to pretend as though we are in love with our insurance companies. People like probably the doctor they see. They probably like going to, if they have to go to a hospital, a certain hospital. They probably like doing business at a certain pharmacy. They like the people delivering care. I think the vast majority of Americans could not care less what the logo was on the card that they present to the doctor when they just want to make sure that that card pays for the care they need. They don't care whose name is on it, other than their own. It's politically impossible. Well, we can get into that in some of the other slides. There are, as Jim mentioned earlier, there are a lot of things that were politically impossible. Universal suffrage, let's end slavery, let's get a 40-hour work week. All of that was impossible, and obviously it wasn't. I'm sorry, you had your hand up, ma'am?
Yeah, it's related to the first point. So what about the people who say we have to wait in long lines now? That it's a little bit related to that you'll be taken away from you, meaning that if you were able to afford health care and you're able to have some sort of boutique care, that all of a sudden if you open it to everybody, that you don't have the same choices that you had in the past, or that you have to wait in long lines. That's the other one I use, long lines.
Right. So
long waiting periods.
I see patients every day. I actually have a practice in East Providence, and I had a patient who, has been waiting and waiting and waiting, putting off her hip operation. She finally can't take it anymore. She wants to go see an orthopedic surgeon. 3 months just to get the appointment, and it's probably going to be another 2 to 4 months before she can get the operation done. And she has pretty good insurance. So even under our current system, there are waits for certain things. Now, if you are, say, a U.S. Senator, you probably go right to the head of the line. But the people who have that special treatment, there's probably not a lot of them. The majority of Americans face delays. In Canada, yes, there are probably longer delays for elective surgeries than there are in this country. That's partially dependent on how Canada chooses to fund its healthcare. If they pumped in all the extra money we're pumping into our healthcare system, the wait times would probably be drastically reduced. But they choose to have a more efficient and cheaper healthcare system than we do. We just have an expensive, inefficient one. But there are waits even here. And then if you think about it, if you have no insurance, what's your wait time? Forever. So,
Can I just make a point?
Sure.
One of the places I worked with the National Health Service in the UK, and there are wait times there, not for urgent issues, but there are wait times for elective surgery. Now, as you saw on an earlier chart that Mark showed, the UK spends less than half of what we spend per person on healthcare. The reason you have wait times is not because of the way insurance works. The reason you have wait times is because there either is or there is not enough capacity in the healthcare system to see people when they show up with a problem right away. And in the US, because of the profit motives, the capacity in the US system is generally good. There are certain specialties like dermatology and orthopedics where, because the specialists restrict to the number of people who can go into those training programs, so the number of doctors in those specialties is restricted, then there are long wait times there. But it's not a function of insurance, it's a function of what is the capacity of the system. Now, our current system has 30% waste in it. You take some of that waste away, the administrative waste, and you replace that with additional capacity, your wait times actually would go down rather than up.
So there's some other things we wanted to get to, and we're kind of running long here, so I'm just going to run through these really quick. Government will limit your choices. Well, we've already beat this one into the ground. If you have private insurance, your choices are already limited because they all have networks. There are doctors you can't see, there are places you can't go. I am every day filling out forms trying to get a formulary exception to medications that people need to take or they've been taking for years that are now suddenly no longer in the formulary of their insurance company. So your choices are already being limited by private insurance. There's the potential for that limitation to go away when you have a universal system that everyone is participating in. Let's see, government is incompetent. Well, government's been running Medicare for the last, since 1964, and Medicare has a lower overhead than any private insurance company does. So Medicare is being run more efficiently than any private health insurance company is being run. So if government is incompetent, why is it more efficient than competent private companies? Hospitals will close, doctors will quit. Who used to go to Pawtucket Memorial Hospital? It's no longer there, is it? Our governor chose to cut Medicaid twice in the last 5 years. A lot of Medicaid patients in Pawtucket, the hospital closed. So in this state right now, we have 4 hospitals that are fiscally solvent. The lifespan hospitals, Newport, Miriam, Rhode Island, and Bradley, which is a child psych hospital, and South County, which wisely invested in expanding its orthopedics department, so they get a lot of revenue from that. Westerly has already sold itself. Roger Williams and Fatima have had to sell themselves, and Care New England is trying to sell itself. Why? Because they're friendly? No, because they need money. They are not making enough money to remain in operation. So that's what's happening right now with our healthcare system. So if hospitals will close, they're going to do so because we are not funding them properly, and our system currently doesn't fund anything properly. Doctors will quit. Well, I'm not going to. If you told me that the amount of time I was spending on paperwork would be reduced by 30% as it is in Canada compared to what I'm doing right now, that my billing costs would be reduced by 75% as they are in Canada compared to what we spend, then I don't think I would quit. I would think, oh my God, finally, I get to actually see patients and not do paperwork. So I don't think doctors will quit. The transition will...
How do doctors feel about it?
Internal medicine doctors, the ones I've talked to, are pretty much in favor of this. It varies by region, obviously. New England is a fairly liberal place compared to the rest of the country. But in general, I think most internists are in favor of this. You talk to anesthesiologists, to surgical subspecialists, they're probably not as uniformly in favor of this because they're worried about their income. But most people delivering primary care are so burdened down with the paperwork, with the documentation. I think we would welcome a change, most of us. Jim, you were going to say something.
Yeah, 50% of younger doctors would favor a single-payer system because they don't want to deal with the administrative hassle that Mark deals with on a daily basis. So I think, like everything else, science advances sort of funeral by funeral, and in this case, the opinion of the medical professional is already shifting in favor of single payer because they see that the current system is, one, it's unsustainable financially, and then 2, it's unsustainable administratively too. So you may hear opposition from doctors, but that is less than it was 10 years ago, and it's going to continue to decrease.
So I'm just going to skip through the next two very quickly. This is a great unknown. That's ridiculous. Most other countries on earth already have something like Medicare for all. So there's nothing unknown about it. We have plenty of examples as to how well it works. Medicare is fragile and will break. This is sort of like the Social Security Trust Fund argument. It's going to go bankrupt. Oh, really? So we're not going to be able to fund it? I think we're still collecting taxes. So these arguments are sort of scare tactics, and they don't really have much basis in fact. So the question one must ask oneself is, why is this stuff being said?
So that's what we're going to answer now. One other observation, though, is that 10,000 people a day transition from private insurance or no insurance to Medicare every day in this country right now as the baby boomers age. And that transition, they're moving to the Medicare program, which, as Mark said, has a 2% overhead compared to the 18% overhead of private insurance. So it's much more efficient. And it's also the most popular health insurance plan in the United States, as judged by patients. So this issue of transitioning everyone to Medicare and things like the sky is going to fall is simply wrong. We're already transitioning 10,000 people a day to Medicare, and the sky hasn't fallen. And we do have the capacity to handle all the administrative operations of Medicare, because guess what? Although your Medicare plan looks like a federal plan, the machinery behind it is actually delivered. The payment of claims and the management of the network and the sending out of EOBs to you and so on, all of that stuff is actually already done by private insurance who contract out their capability to do these things for their own plan. They contract it out to the government. It's called a Medicare carrier. And so we already have the capacity to deliver Medicare for all in this country. It exists right now today. All you have to do is take the Medicare rules and load them into the private insurance system and pay them to run Medicare claims for all 330 million Americans. So this is not infeasible, it's actually very feasible to do. So why are we being told these lies? Go ahead then. So we're going to go through an exercise now from the Watergate days where Bernstein and Woodward were told by Deep Throat to follow the money to find out what was going on with the Watergate scandal. So let's do that. So here is an article by a doctor who actually came here to Brown to speak and argued in front of an audience that some of you, I think, were present at. And he said that we need to have Medicare for all because it's the only sensible way to insure people in the United States. But it's politically impossible to do this, and so forget about it and think about tweaking Obamacare. Now this is Biden's position, basically, and some of the other Democratic candidates. There are two candidates, Warren and Sanders, that really support Medicare for all, and the rest are on the fence or have some sort of obfuscation of one kind or another. So why, hang on a second,
Sorry.
So why are we being told this by people like Ezekiel Emanuel, who has an extensive career in academic medicine and in government too, and as a researching medical scientist? So think about this for a second. Go ahead then, Mark. And these are the people that he gets fees from for speaking. And in that list there, which I'm not going to go through, there are private health insurers and also the trade organization for the health insurance industry in the United States. There are specific pharmaceutical companies and also the trade organization for pharmaceutical companies in the United States. And of course, both of these people are lobbying vigorously against single payer. And they use people like Zeke Emanuel to stand up and say, well, I'm a doctor, I'm this at the University of Pennsylvania, and I did that in the Department of Health, and here's why single payer is a bad idea. What he doesn't tell you is that his money is coming from insurance, pharmaceuticals, medical device manufacturers, and large providers of healthcare. So go ahead. And this is who he is, with all these titles to his name and so on. And he's not the only person who's doing this. But who is he working for? Go ahead. He's working for something called the Center for American Progress.
Oh, brother.
And the Center for American Progress is an organization, a think tank, set up by John Podesta, who was worked in the White House at one point. And it's set up to develop policy for the Democratic Party nationally. So what we have is pharmaceutical companies medical device manufacturers and health insurers funding the development of democratic policy on health insurance. And the result of that is this. This woman here is the head of the Center for American Progress. What did she do? Go ahead. She cast the deciding vote to keep Medicare for all off the Democratic Party platform in 2016. So what we have here, when you follow the money, is that pharmaceutical companies, device manufacturers, health insurers, and large providers of healthcare are actually funding an operation which keeps Medicare for all off the Democratic platform. And that is why you are being told that Medicare for all is not feasible, it's politically impossible, it's too expensive, and so on and so forth. Because if we had Medicare for all, those four groups would all have less revenue, and for those of them who are in the for-profit arena, their stock price would go down. And we all know that the only metric in America today that really counts for anything is shareholder value and your stock price. So this is more listing of people who were funding this activity. So this is the money that we've been following, and you can see what's being done with it. What do we have next, Mark?
I think that's the end of the topic.
We'd be pleased to hear that we're done. We're eager for questions. Could we have the lights on, please, for that? Thank you. Yes.
I just have a general question about the number of doctors that are entering the profession. Like, if you look back a couple of decades and over a couple of decades, is that growing now for the funding proposal to work as well, or could there be a shortage of doctors?
Well, I spent some time training physicians, and I've got a position where I was involved with that. The number of doctors in the United States is limited by two things. One is the number of medical school positions, which has increased significantly over the last 20 to 30 years. The new medical schools have opened. And then the second thing is the postgraduate training of doctors, where they're actually learning their specialty work in the hospital, 3 to 5 or 7 year program. That is funded by the federal government, by the way. And that number is set by an organization which is basically dominated by doctors. There are more training positions in the United States than there are medical school positions, which is why we have so many foreign trained physicians in the United States, because they come in at that level, already have an MD degree or the equivalent of that, and then they train in our hospitals and then they go on to work here. So the short answer to your question is that we clearly have a capacity issue in some specialties, including primary care, and you solve that not by monkeying around with the insurance, you solve it by training more doctors in those specialties. And there's certainly no reason why, with a Medicare for All program, which was responsive to the patients, rather than responsive to the competitive issues with doctors, you're likely to get more training positions funded over time, which would give us more access to doctors.
We have been doing this to some extent. The military, for instance, will pay for your medical school, but you have to then go into the military and become a military doctor for X number of years, compared to the number of years your education was paid for. The public health system would pay for your health insurance if you would agree to go out and essentially function as a primary care physician in underserved areas such as Appalachia, the inner city, Indian reservations. There is no reason why that program can't be expanded under a Medicare for All system. Under the current system, less than 1% of graduating medical students express an interest to go into primary care to do what Jim and I do, or what we have a shortage of. You could fix that if you change the financial incentives.
Thank you.
But you wouldn't get more doctors doing that. You'd just get doctors that have less debt when they graduate.
Right.
To get more doctors, you need more training positions.
Right.
Yes, sir.
So one question I had is about the reimbursement rates of Medicare and how that compares to private insurance, and whether that's a point of resistance for the medical community, where if they accept everybody on Medicare, would they be getting less revenue because the rates for a procedure are lower and it's set, by the government agency. So I think that's a question I wonder about And would that be made up because now you have more money to work with, to maybe could increase those rates a little bit more?
Well, I think, let me talk to that first, and then Mark will have an opinion too, I'm sure. But if you think back to, we had a slide that was a pie chart that somebody asked me a question about, okay? Now that pie chart represents who's paying for healthcare, who has the leverage, so to speak, because it was about dollars, that's what we established. And the majority of the dollars were paid through federal programs, and about 30-35% was private. If you ask the question, who is allowed to negotiate costs and what the insurer pays for a service, which is what you're talking about in the sense that's what the hospital gets or the doctor gets, then the only part of that pie chart that can negotiate is the private insurance sector. So you've got a so-called market in which 70% of the people in that market, or the dollars in that market, are not allowed to negotiate. And the 30% that can negotiate is made up of, typically half of that, 15% of the total, is blues, like Blue Cross Blue Shield, and the other 15% is sliced up between Aetna, Cigna, and small insurers, and so on. So there's nobody in that pie, there's only 30% of the pie can negotiate prices, and there's nobody in that pie that has a bit, doesn't have and nobody has the 30%, they all have a little bit of it. So this is partly why healthcare costs are so high, because there's no proper negotiating leverage. Now Medicare and Medicaid peg their costs by statute at a percentage of what the private payers paying, and that percentage is less than 100%, which is why doctors and hospitals complain about it. But there's no reason at all why, when you have Medicare for all, that you can't up that percentage, set a new rate, and enough. And what politician is going to sit in Washington and refuse to vote for a bill that's going to fund the local hospital so that it doesn't close? You're going to have the funding of hospitals responsive to the voter instead of responsive to Wall Street. So I think your question's a very good one. It needs to be answered, but I think again it's a question that can be answered.
And when you think about it now, how are these rates set? Are they set based on cost of doing business for the hospitals and doctors? No. It's a business negotiation between the insurer and the physician, the insurer and the hospital. One of the reasons why Rhode Island hospitals are closing, in every state there is a hospital system, sometimes more than one, depending how big the state is. That's the prestige hospital. The insurers have to do business with it because you can't sell your insurance to employers if you don't cover, say you're in Rhode Island, we don't cover the Brown academic hospitals. What employer is going to want to offer insurance where their employees can't go to that hospital? In Connecticut, it's Yale New Haven. In Massachusetts, it's Partners. Those hospitals then negotiate higher rates than others do. And we see the consequences in Rhode Island. We see Lifespan doing well and offering to buy Care New England. Care New England trying to sell itself. If we had rational negotiation based on the actual cost of doing business, the actual cost of providing care, this would not be happening. So yes, Medicare rates are lower, but right now the healthcare system is so fragmented the way we fund it, and costs are frequently hidden because a lot of these negotiations and contracts are proprietary. They aren't available, the data is not available to the public. We don't know what the terms of the contracts are. So when you have a Medicare for all system, everything is transparent. We know exactly how much is being spent, we know what's being spent on, and we can start making some intelligent decisions about what needs to happen in Rhode Island. For instance, South County, we're going to make more money by offering more orthopedic procedures. Well, so we're going to raise funds to build another orthopedic wing. If you have a Medicare for all system, you've got some sort of state entity that says the state does not need 50 new orthopedic beds in South County. You're not going to do that. Right now, there's no way to regulate these things. So our healthcare system, Medicare rates. The problem with all of these rates is they're not based on the actual costs. They're based on negotiating and on other things that don't really make sense in the long run. So hopefully, if we can get to a rational system, this is how it's done in other countries. Hospitals are not closing down left and right in Sweden. They are here. So yes, Medicare rates are a bit lower than private insurance, but right now that's because these rates are almost arbitrary.
Let me tell you a story about negotiation.
Oh yeah,
we'll get to you in a second.
Yeah.
But this is a story worth telling.
Appalling.
To show you the quality of negotiation in healthcare. That I was involved in a situation where, as an insurer, we were negotiating with a health system in an effort to create something called an accountable care organization, which is where doctors and hospitals and insurers get together and basically try to set up an arrangement where the doctors and hospitals would get more patients, but they would be paid less per patient for whatever it was that they were doing. So they're basically trading price for volume. But this is something that was established in the 2000s, and it's basically gone away. And it's gone away, and I'll show you why it's gone away in this story. So I'm sitting there on the insurer side of the table, and the hospital CFO's on the other side of the table, and the Aetna folks are on my side of the table, and the chief medical officer and the health systems there. And so we all shuffle our papers, and then they get started, and they look at me and they say, "Hey Jim, what have we got today?" And my job was to find opportunities to save money. So I ran a data shop, and that's what I did. So I said, okay, well, we've got 1,000 MRIs we've done in this health system last year on our patients, and we're paying $1,200 per MRI. And down the street there's a freestanding radiology center owned by the radiologists where they charge us $400 per MRI. So we could send these patients down the street and we'll save $800 per MRI. And the CFO leans across the table, looks me in the eye and says, "Jim, we're not going to do that." And the Aetna folks say, "Okay, what you got next, Jim?" Now, so the question I have for you is, who's wearing the black hat in the room? Is it the CFO? Now the CFO's job is to meet his payroll and at the end of the year have a little money left over for capital things next year. So if he's not going to give up $1,200 of revenue for when he's going to get nothing back in response. So at the end of the year, if he keeps that $1,200 for the MRIs, his board will be very pleased and he's going to get a bonus. He is actually doing his job. In the terms that he's set for his job, he's wearing a white hat. And on the health insurer side of the table, then their job in a for-profit health insurance company, it ultimately is to increase the share price, the value of the stock, the shareholder value. And the way you do that in any company is you increase your top line revenue, you increase your margin, and you increase your prospects of further growth of that top line revenue. So if you're, as an insurer, you're paying $1,200 an MRI because the CFO won't give you a deal, then you have to set your premium to cover that $1,200. The only way you can get any advantage by paying $400 for an MRI is to lower your premium so that you get more business coming into the insurer. So from the point of view of the insurance company, lowering the cost of services reduces their top line revenue as a corporation and reduces their prospect for further growth because their revenue projection is not going up, it's going down. So the insurer is also doing its job by keeping the cost of the MRI high. It's doing its job not for people who live in that community, but that's not its job. Its job is to increase shareholder value, and that's what it's doing. So the people on the insurer side of the table are wearing a white hat. You, as a patient or as a business owner in that community, are not at the table at all. That's the problem. So the ideal role of negotiation in the system that we have at the moment is really, we don't really have negotiation. We have people feeding at the trough is what we have. So there was a question there.
I was just going to say, I think you guys presented some amazing stuff tonight, just fantastic facts. The slide that blew me away was that slide that showed where life expectancy only goes up at age 65. And that was amazing. But I'm curious why, even like people like Bernie Sanders, I don't even hear some of that stuff coming out of his mouth. Maybe he covers that stuff, but some of those other facts you don't hear enough about. And I don't even hear him make that distinction that, you know, a socialist system would be where hospitals, doctors, everybody's owned by the government. And, you know, so this is not a socialist system that he's proposing. So I don't even hear that distinction made. But I would love to hear him make some of those arguments you guys are making.
Well, one of the problems that we have in talking about this is that we need a prepared audience, which we've had tonight. So thank you very much.
Right.
Because it's a complicated issue. You have to understand how ordinary insurance works, first of all, which is why we begin with insuring your house and your car. And then you have to see that health insurance is just different. And that means that you have to offer health insurance to people in a different way. You can't link it to things like employment and have people either, you know, insured or not insured. It just doesn't work well like that. And it also means you have to pay for it differently. You have to pay for it through a progressive tax. because the cost of your healthcare is not linked to your income. You know, rich people don't have expensive illnesses and poor people have cheap illnesses. Anybody can get any illness. So you've got to get people to understand that before this makes sense. And then you've got to be able to articulate, like, who's really paying people to say this isn't going to work. And I think the politicians, and we have this problem, we sweat over these, what we can talk about, because it's so complicated that you can't have a 2-minute elevator speech. There is no like single phrase that's going to capture the American public's attention, because this issue is complicated. And those people who are advocating for no change use that to obfuscate and confuse people and frighten them, so that they say, you know, your Medicare is going to go away, which is ridiculous. People who have Medicare now aren't going to lose it. It's just that everyone else is going to get the same thing. So it's a uphill sledding, but I think in the end the public is, you know, you can fool some people some of the time, but you can't fool all of the people all of the time. And in the end, both the professionals, as I mentioned earlier, and the public is going to realize that the current system is unacceptable, and business is going to realize it too, because the costs are out of control. So I think we have time to go, but there are reasons that you don't hear what we're saying tonight, because I think it's intrinsically, the message is too complicated to be handled in a soundbite.
Just curiosity.
Yeah.
I heard rumors that like every doctors give prescription to the patient, you will get a percentage from the pharmacy. Is that true?
That's illegal, actually. It's, what statute is that a violation of? I can't remember that.
Start law?
Yeah, I think it's Stark Law, that's right, yeah. No, that actually, if you actually know that a doctor is doing that, you should report it to the police, because that's frankly illegal. Yeah, no, you can't do that. Yes, sir.
So you described a single payer system, and it looks like there's no room for private health care at all. Some of the Democrats are proposing a middle of the road solution that calls for both, like a hybrid, a single payer and an opportunity to keep your health care. What are your thoughts about that?
Well, my thought is that it's not going to work for the reasons that I set out. If you have more than one payer, and what will happen if you have a public option and you have private insurers, is the private insurers will do what they're supposed to do legally, which is to maximize the shareholder value of their company. And one of the ways they'll do that is to shove the sickest people onto the public option. And then the cost of operating the public option will go up. And then the Republicans will say, see, government can't do it, and the public option will go away. So it's like an all or nothing phenomenon. You know, you either have slavery or you don't have slavery. You either have gay marriage or you don't have gay marriage. You either have a single payer system or you don't. And when you don't, then you have the current mess that we have now. So these partial solutions are being proposed mainly by people who are funded by the Center for American Progress, and they're being proposed to confuse the issue, because if there is anything other than a single payer, then private industry in drugs, devices, and insurance will continue to have an opportunity but they will be able to maintain their profits, basically.
We know this happens because there are really excellent historical examples. In 1972, under Richard Nixon, the mandate for an employer-based healthcare insurance system was formulated. This was basically to preempt a single-payer system that was being advocated primarily by Teddy Kennedy. Interestingly, Nixon's radical new plan of having the employers help to pay for health insurance was actually pretty much a copy of a plan that was passed by Otto von Bismarck 100 years earlier in the Zweite Reich in Germany. So it was hardly progressive, but as part of that bill, which is not normally remembered, renal dialysis was suddenly declared a Medicare benefit. So if you were an end-stage renal disease and had to go on dialysis, Medicare would agree to pay for your dialysis, because dialysis is tremendously expensive. It goes on for years, and it's a money loser for the private insurance industry. They were, of course, at the table, and they managed to foist that cost onto the public sector. A study done of HMOs in the 1990s comparing people, the average age and the average health of people in the 6 months prior to joining the HMO and the 6 months after the HMO, showed that people who were about to join the HMO were significantly younger and healthier. People being booted out of the HMO were significantly older and sicker. Again, as Jim says, it's not that these are bad people running the insurance industry, it's just that they can't do business if they lose money. So when you have a system operating in parallel with a federal system, they have every incentive to improve their efficiency and lower their costs. And the best way to do that is to get rid of people who cost money. I mean, this is called lemon dropping and cherry picking. You pick the cherries, they're sweet, they make you money, you drop the lemons. There's no way around that as long as you have private health insurance. They have to do this.
Thank you.
Yeah. Oh.
Yep, you ma'am.
So I have two questions that's really more about resistance. And one is wondering to what degree that, all the workers who are working in the insurance industry, is that like a point of resistance as well? In other words, is this system rather like the military-industrial complex in which so many Americans are dependent for their jobs in this industry? That'll be hard, point of resistance number one. The second one is a little bit shorter, which is that why is Senator Reid resistant? Because you've gone and talked to him several times, so is he being funded by the Center for American Progress?
I'll do the first one, I'll do the second one. So you're right, there's going to be a transition. We live in a capitalist society, which is capitalism is successful because of creative destruction, where industries that are not effective are cast aside, and people in those working in those industries have to go and work in something else. So again, if I was talking to an audience of business people, I would make that point if someone asked me your question, that this is actually capitalism at work. And the second thing is that what do we have here?
Actually, my question is, would the workers themselves be upset? So in other words, like if you were saying you're going to take away a defense something or rather, that would make the populace...
You mean the workers in health insurance or workers generally?
No, workers like, not in health. I mean, yeah, in health insurance, yeah.
Okay.
Like,
So how long does somebody employed by a health insurance company stay in the particular position they're in on average?
I don't know.
1 year.
1 year.
Yeah, the other thing to keep in mind is that 60 million Americans change their job every year.
Yeah.
But changing a job is like, it's not, it can mean that the sky is falling if the circumstances are such that you lose a job and you don't have something to go to. But as a capitalist economy, then we are capable of handling the situation where some kinds of employment dwindle, like coal mining is now, and people move it into other jobs. Now, for me to say this is not going to be unpleasant and painful for some people is wrong, because it will be upsetting to some people. Many people will continue to work in health insurance because they will have to deliver the sort of back office bureaucratic processes that lie behind Medicare, and the private insurance world is already doing that now. And if instead of 60 million people on Medicare, there's 330 million people, they're going to need to retain many workers. But there are people in like sales and marketing in health insurance and billing operations that are going to become much simpler, that they will have to find another job. But as we do live in a capitalist society, we don't live in a socialist country where employment is guaranteed, then this is, it's in a sense, it's a price that's going to have to be paid. Now, are they going to be happy about it? No. But nevertheless, in the general interests of the country as a whole, this is something that has to go on. You want to talk about Senator Brown?
Sure. So we've talked to Senator Reid several times, and again, I cannot crawl inside his head and see exactly what he's thinking, but the impression that I get is that Senator Reid considers himself the defender of the military retirees in this state, and also a person who is instrumental in bringing in defense-related jobs into the state. So when you start talking about going to a Medicare for All program, you are pretty much saying that you will be getting rid of some programs that veterans like TRICARE, a military veterans insurance plan. We point out to Senator Reid that if you have TRICARE, there are certain doctors who will not see you. There are some places you will not be able to go, and you probably will have a wait time to get certain surgical procedures done. A Medicare for All benefit removes those things because either you play ball with Medicare for All or you don't see patients. So we point out that in all likelihood, at least as they are formulated in the bills under consideration, the benefits under Medicare for All bill our plan would be superior to those of TRICARE. Senator Reid, I think, does not consider it that it's his job to try to educate people on this issue. His job is to defend what they already have. And so, again, I disagree with him there, but that seems to be his job. And when, in his defense, no pun intended, the senators are supposed to be knowledgeable about everything, about defense industry things, about international trade, about defense, diplomacy, all sorts of things. And as I think we've all come to the conclusion this evening, the issues surrounding the funding of healthcare are quite complicated. So, how expert can Senator Reid be on how healthcare is funded? As knowledgeable as he wants to be, and his staffers can make him. But I don't think, that's not his primary focus. And he feels comfortable with military retired benefits where they are. He doesn't feel that he needs to change things.
Can I ask one follow-up on what you were just saying,
Sure.
and then I have my actual question? And you said Senator Whitehouse just recently changed his mind?
So the Sanders bill got reintroduced last summer, not this summer. And White House was one of the first signature, one of the first sponsors on the bill. And that was in August, I believe, but 2 months earlier, we had gone to one of his town hall meetings where Jim got up and actually said, you don't have to do it all at once. You could just lower the Medicare eligibility age by 10 years every year. And you could see Senator Whitehouse's eyes kind of, well, that's a thought. And 6 weeks later, suddenly he's a sponsor. So I think, Sanders won the Democratic presidential primary by double digits. I think that weighs on politicians' minds. And the fact that, you had some people who were actually offering him sort of creative solutions to make this transition. I think he changed his mind. Okay, my pleasure. I think he is not totally sold on this idea, but he's much more comfortable with it now than he was. Congressman Langevin, on the other hand, I think just did it because he was probably staffers told him, you do this or you're dead meat. It's just, the numbers are against him.
And your second question or your first question?
Yeah, so my first question was in regards to the people who are funding the doctor manual.
Yeah, the Center for American Progress funders.
Yeah.
He's not the only one though.
Sure. I was just wondering.
Happens to be one we've come in contact with recently.
Right. I was just wondering if you happen to have there are a long list of funders, and you pulled out the insurers that were funding him. I was wondering, proportionally, if if are they funneling a lot more money than all of the other people combined? Do you have any idea?
We don't know. We don't have a complete list of funders. Those are the ones that have been identified over several years.
Yeah.
We don't know.
Okay. I'm just wondering if those 5 people are giving more than all of the other listed people.
Well, they're giving enough to make Zeke Emanuel say what they want to say.
Right. And overall, we do know that, this is Congressional Budget Office data. As a percentage of their capitalization, the pharmaceutical industry contributes more in political giving than any other industry. But they have a lot more money to do it. Their profit margin per capitalization is also higher than any other industry in the Fortune 500. So they make a lot of money and they disperse it generously to keep themselves profitable.